Today I'm tasked with talking about respiratory medicine and obesity and the costs involved. And I've just recently been tasked to talk about it a lot quicker. So because of the time limit, I have no particular disclosure other than that I'm honorary treasurer, and a new disclosure that I have, after much begging, our dear Dr. Michelle Yun have now started to treat me for my obesity. So I'm starting treatment. So hopefully I'll get thinner soon, okay? So anyways, we're going to start by approaching this particular topic in two directions. One is disease entities associated with obesity, and the other is clinical conditions that are affected by obesity. The first are more well-known, obesity and its relationship with sleep, which is sleep medicine under respiratory medicine. So the most commonly known is obstructive sleep apnea. I know a lot of you may be surgeons, endocrinologists, general practitioners, so we will take this step by step. So obstructive sleep apnea, in essence, is a disorder in which breathing is repetitively interrupted during sleep due to the collapse of the upper airway. Now, when there is a complete cessation of the breathing, we call it apnea. And when there is a significant airflow reduction, then we call it hypopnea. And when we put that two numbers together and then give it an average and an average out per hour, then we get this apnea-hypopnea index. Now, normal people do have a few events here and there over the night. So we score it 0 to 5 as being normal, 5 to 15 being having mild sleep apnea, 15 to 30 being moderate, and for those patients with severe sleep apnea, those patients have more than 30 events on average per hour during the night. In GIST, patients have these upper airway muscle that tends to relax and it collapses when they sleep and therefore causes the obstruction. These obstructions are particularly severe when they inspire, because when you inspire, it actually sucks in the air, which causes a negative pressure at the airway, which actually worsens the obstructions. So in GIST, that is what obstructive sleep apnea is. Now, these are common symptoms that we get from obstructive sleep apnea: excessive daytime sleepiness, poor concentration and coordination, fatigue, lack of energy. Patient might complain of sleep fragmentation, going to visit the bathroom multiple times per night. But these are also symptoms of urban living. Everybody has it. So rather quite specific, but sometimes less common sleep apnea symptoms includes the following. These should give you an alert or red flag symptoms that these are symptoms that should make you think about referring this patient for further workup, including patient reporting gasping and choking sensation at night, the partner reporting that the patient have pauses during their sleep, breathing during their sleep, followed by loud snoring, explosive loud snoring, and a very not so much taught in school, but very, very reliable sign if it's the patient can hear themselves snore. Another source of referral that we get for workup for obstructive sleep apnea is for obese patient, for patient that are acromegalic, or patient with resistant hypertension or polycythemia that have gone through the first level of workup, so to speak, and they couldn't really find out why, and the referring physician wants to know whether obstructive sleep apnea is the cause of their problems. Ultimately, obstructive sleep apnea is diagnosed by polysomnography. This is a tracing of a typical polysomnography. No need to know the detail, but ultimately, I think this gives a pretty good idea to the audience of the pathophysiology involved.